It's so good to have you joining us today. My name is Anissa Mitchell with PMD Alliance, and you are here for the Thriving with Parkinson's Disease live stream. So we want to welcome you to this program. This is a foundational program that we're doing in partnership with our friends from Amneal. And what we're going to do is cover what to expect, how to advocate for your best treatment, and lifestyle choices that can improve your quality of life in regards to Parkinson's disease. If you've been a part of PMD Alliance programs before, you know that we are all about you being educated consumers and knowledgeable self-advocates. So this program is great, whether you are newly diagnosed and just starting on your journey, or you've been diagnosed a while, but you're kind of wanting to know a little bit more of how to take an active role in understanding and managing your disease. So I know you're going to gain some insights today, some tips to help you understand your symptoms, ways to manage them, and how to communicate effectively with your doctor. We are going to be recording today's program, and we also will be taking questions at the end of the presentation. So feel free as we go along to pop those in the chat. And of course, if you're willing, just give us a shout out. Let us know where you're joining us from. We always like knowing where people are coming from and connecting to us from. We like to look at that and notice around, an average of 35, 36 different states on any given live stream. So it's really neat to see where people are joining from. And I am going to introduce our speaker today. With us, who is going to be presenting, is Dr. Padma Mahant. She is a movement disorder specialist in Phoenix, Arizona area. She also is a clinical assistant professor of neurology at the University of Arizona in Phoenix. And she is also director of medical affairs at C&D Life Sciences, where she's working part-time, which allows her to continue to have some direct patient care in her private practice. So she is our expert speaker today, and I am going to hand this over to her. And thank you, Dr. Mahant, for joining us.
Thank you so much, Anissa, for allowing me to be here with you all today. And PMDA, all of you do such a great job, and it's really my honor to present this topic to you. So let me just make sure that you can see my slides. And should be in slideshow mode. All good? All right.
All good to go.
Thanks, everyone. All right, so we're going to be talking about thriving with Parkinson's disease. And really, this is an introductory topic. As Anissa said, we're going to be learning about Parkinson's, sort of what to expect and how you can advocate for your best treatment options. Some of you out there, if you're, sort of early in terms of your diagnostic timeline, then hopefully this will give you some information in terms of sort of where things are as far as treatment and what to expect. For those of you who are veterans with Parkinson's, some of this may be review for you. I'm happy to, review questions at the end that may be a little more pertinent in terms of where things are along your diagnostic timeline. We do, though, however, want to make sure that we keep this confidential. So everyone here is going to keep things confidential. We've all agreed to that. But, when you ask questions, if you can kind of keep them fairly general and not too much of the personal, just to make sure that we're, respecting your privacy and your confidentiality. And so the program features me, a healthcare provider, and it's not, though, intended to provide medical advice or care. We leave that to your clinician. We think that that relationship is extremely important for you to maintain that personal relationship with your healthcare provider. They know you best. We don't have all the information, even if you give us details, and we certainly don't want to get in the way of that management with your healthcare provider. I have been compensated by Amneal, so I want to thank Amneal for bringing this program on as well through PMDA. And so just beginning here in terms of Parkinson's disease, as many of you know, this is the fastest growing neurological disorder and impacts millions. There was recent legislation that was signed that is aiming to end Parkinson's, really is the goal with that. And with that, hopefully we will have research dollars and more of a legislative backing for treating, managing, hopefully curing this condition. And so in terms of the growth by 2037, 1.64 million will have Parkinson's. As most of you probably already know, it is characterized by a loss of dopamine producing cells in certain parts of the brain, the midbrain or the substantia nigra. And the primary symptoms are motor, but the disease, the condition also includes non-motor symptoms. So we're going to go through that in some detail. So let's start with the who, what, and why of Parkinson's. We do know that more men are diagnosed than women by a ratio of 3 to 2, and we're not sure exactly why that is. Hormone effects have been studied, but nothing definitive in terms of why there is that preponderance of PD seen in men. Age of onset tends to be greater than 60, so it is a condition that we generally do see in folks who are older. Although I will say that we see a number of patients with young onset Parkinson's as well. And unfortunately, those folks may be a little bit more delayed in terms of their diagnosis because it's not expected in a young person very often. So it is really important for neurologists to be aware of that potential for young folks to develop Parkinson's as well. About 1% of the population over 60 will have PD. And by 2037, 1.64 million will have the condition. And genetics and exposure to environmental toxins are thought to be causes. So in terms of genetics playing a role, what this means is not necessarily that if you have Parkinson's, there is a definitive risk for all of your offspring. But what it does mean is that we can see that there are certain mutations that do increase your risk of Parkinson's. And some of these mutations can actually be tested for through a free program called PD Generation. So if those of you have participated, want to share your insight in terms of what that program looked like for you at the end of the session, that would be great. But in terms of just generally sort of how it went and what the process was, that might be helpful for others considering it. But it is a free program. You send away for a kit, cheek swab, send it back, and then they get results back to you. And then there's genetic counseling as well. So the genetics basically do not mean, like I said, that you're going to necessarily have offspring with an increased risk, but it is important to consider because there may be different approaches even to treatment based on what genetic mutation may play a role in your Parkinson's condition. And so it may be a little bit different than a typical PD without a genetic mutation associated. So just a little information there on the genetics piece, and about 13% of folks through that PD generation study that have been tested so far show positive genetic mutation among the 8 mutations that they're looking for. Exposure to environmental toxins can also be a risk factor. So TCE has been in the news, especially for those of you that might be aware of Camp Lejeune, is a base in North Carolina where there was heavy exposure to TCE in the drinking water, and it's a solvent as well and used in machine cleaning. It's in a number of different consumer goods, actually, even decaf coffee. And so that is something to consider. Pesticides. Many of you may have heard of Agent Orange, which was a Vietnam War area defoliant, and there was an increased risk of Parkinson's in veterans exposed to Agent Orange. But similarly, we do think that there are pesticides that have been implicated in terms of the risk of Parkinson's as well. Rotenone and such have been associated. So this is all to say that basically these two things can play a role, and also head injuries. So if you've heard of Muhammad Ali, I was among some young interns, and I had a picture. I was fortunate enough to meet Muhammad Ali when he came through the Ali Center here in Phoenix. And the young folks did not know who he was. But I'm happy to say that once I said float like a butterfly, sting like a bee, there was one that piped up and got it. So I was very happy about that. But it does mean that I am getting older, unfortunately. So anyway, that is a risk. So head injury, he was a boxer, that is a risk potentially as well. So those three things are sort of potential risks that we see, but we don't identify them in most patients really. And so that's why it's called idiopathic, which means we don't know the cause. And so as far as what's happening though in the brain, we do know that there is a loss of dopamine. Okay, so this is a neurotransmitter that carries chemical signals from one cell to another, and it's part of this complex circuit called the basal ganglia. And that circuitry is really responsible for movement. And so this enables motor function in your body. So it allows you to move. And it's almost, I consider it sort of the automatic function of movement. So things that you don't normally have to think about, speaking, walking. And folks who have Parkinson's may have trouble with these sort of automatic movements. And in Parkinson's, there's insufficient dopamine, and that leads to difficulty with normal movement. And so what are those motor symptoms? Tremors, that's one. So it could be a slow tremor of the hand at rest. We're going to kind of dive into that a little bit in terms of the features of that tremor. So it's important to know that not all tremor is Parkinson's. There are other potential causes. And essential tremor is one, physiologic tremor is another, but there are some features of the tremor associated with Parkinson's that we'll review. Rigidity or stiffness, bradykinesia. And so for any of those who have taken Latin out there, brady meaning slow, kinesia meaning movement. So slow movement overall, or having trouble moving. Freezing up. So this often can happen with walking in small spaces or with turns. There may be difficulty in continuing movement. And so short steps can happen, and just getting stuck can happen. Stoop posture, shuffling gait. And what's important to recognize here is these motor symptoms. Medications can help to some degree, but physical therapy is extremely important in terms of improving some of these issues that folks may be having. Stability and balance problems when standing or walking, and then difficulty with speech and swallowing. And that's where we, in terms of speech and swallowing, we will enlist the help of a speech therapist who also works on swallowing as well. We might do a modified barium swallow to see what's happening. And then in terms of stiffness, that can be associated with dexterity issues, and that can be helped by working with an occupational therapist. So all of these motor symptoms, while they can improve with levodopa, some are difficult and resistant to treatment with levodopa. So it may treat tremor or stiffness or slowness to some degree, but if you have ongoing balance problems, ongoing dexterity issues, ongoing speech and swallow trouble, then enlisting the help of our allied health professionals, PT, OT, speech, is very helpful. Okay, so non-motor symptoms. So this really has to do with your body in general, separate from movement. Depression, anxiety, fatigue, constipation, urinary urgency, pain, loss of sense of smell, sleep disorders, acting out your dreams, slowness of thinking. So all of these add up to non-motor symptoms. And what's important or interesting about this litany of symptoms here is that many of these symptoms can predate the motor symptoms. And with that predating motor symptoms, especially REM behavior disorders, so acting out dreams in particular, may start 10 years before motor symptoms. And so that potentially means that if we can sort of determine the risk of those patients who have RBD, a very specific disorder, and determine that risk, then potentially we can consider treatments that might be disease modifying. And they may be lifestyle. It might be diet, exercise, which we'll get to a little bit later as well, but that might slow the potential development of motor symptoms. So the medical community is really interested in that population in terms of determining, okay, how can we determine risk? And then what can we do about that potential risk once we determine what that is, and once we determine that we can actually definitively identify that cohort of patients. So that research is ongoing. But these non-motor symptoms don't start once you develop motor symptoms. So sometimes they start. Some of these symptoms may start when you begin developing motor symptoms, or they can be amplified as you develop motor symptoms. So these non-motor symptoms can continue throughout the course of Parkinson's. In terms of that, the sort of specific features of Parkinson's tends to be unilateral. So weakness or fatigue or stiffness that starts on one side, as well as tremor. And that tremor at rest that we were alluding to before, that happens just when you're resting. Generally, initially at least, doesn't happen when you're going to do things. So when you're carrying things, or when you're eating, for example, or holding your arms out. However, over time, sometimes that can become more prominent, and it may be a little more difficult to distinguish Parkinsonian tremor from essential tremor, for example. But generally, when it starts, it tends to be on one side. It's a slow tremor, a pill rolling, which really alludes to the to and fro type movement between the thumb and the fingers that you see with Parkinson's. And then that asymmetry, again, one side affected more than another, and the symptoms can change over time and usually do progress over time. Your symptoms, though, may be different from your neighbors or your friends in the support group. So often, patients will wonder why their treatment regimen is a little bit different than their friends or their neighbors. And of course, sharing your symptoms and sharing your experiences with treatments are very important. Understand that your symptoms may be completely different than someone else's. And so discussing those individual symptoms is very important. So if you hear that, another patient has gone on a specific medication, it's certainly good for you to ask about that medication with your healthcare provider, but understand that there may be reasons based on your symptoms in your particular case that it might not be appropriate for you. There may be other medications that are more appropriate. So taking that active role, talking to your doc about any of the questions that you have, any of the symptoms that you're having, and as they change is very important. Also, work with your doctor to discuss treatments requiring a lot of doses during the day, because I'll tell you, there was a study that was done of nurses and doctors, and we should know better, right? We're in the healthcare field. And so when nurses and doctors were asked to take medications more than, I think it was 2 or 3 times per day, they really fell off in terms of their compliance. So nurses and doctors are not immune to this difficulty in terms of remembering your doses day to day. It can be quite difficult. So some tips that I've heard of from patients, some folks will write in a little journal what time they take each dose of the day. So if they have 4 doses in the day, they'll start with their first dose, write the time so that they can go back and remember, oh yeah, I took that dose at that time. I also heard of another patient telling me about a really neat trick, and I think guys and girls can do this. It may be potentially a little more favored by our female genders, but bracelets indicating whether you've taken your dose can be very handy. So you put all your doses, let's say it's 5 doses in a day, you put it all on one hand. When you take a dose, you move that bracelet over to the other side. So you remember that you've taken your morning dose, you've taken your second dose and such. So I thought that was a pretty handy trick. I always learn from patients. They're always coming up with neat tips and tricks. And I hope that they're able to share those in support groups. But if not, I'm here to share some of them with you as well. So certainly take your medications as prescribed. A lot of times we will tell patients that, sometimes it's a matter of sort of determining as you go what dosing you will need, what timing you will need. So it's important to stay within those parameters. So certainly if you're having issues, if you have an appointment that's 3 months down the road, don't hesitate to call the office and say, Doc, I had an issue with this medication. I had a side effect. It's better not to just stop it and abandon it and wait 3 months. It's always a good plan. If your doc has something in mind, reach back out to them. Nowadays there are a lot of portals, there's, phone calls and ways that you can voicemail and such that you can actually get through to your doc and be able to tell them what's going on, so that you have a plan and that you're not losing those 3 months, until you get to your next appointment. So be sure to communicate well with your doctor, and don't feel like you need to hesitate, between appointments in terms of reaching back out to them. So daily life with Parkinson's and the on-off cycle. So periods of the day when you feel relief from your symptoms are considered on symptoms. And then during those times, that good on time, we're hoping that you're free from uncontrollable movements, so dyskinesias, and we don't want those movements to impact your daily activities. So often when you're moving a lot, and if you don't know what dyskinesias are, if some of you have seen interviews with Michael J. Fox, often he has dyskinesias. He has a young onset form of Parkinson's. And so young onset folks tend to be more prone to significant dyskinesias. And so the goal is to make sure that your on time is free of this extra movement that can cause you to drop things or affect your balance. And so we want to make sure that that on time is really time that you're able to move in the way that you want to move. And tracking exercise and physical activity with the help of a care partner is also very important. I talk to many patients who tell me that they need to get their stretching, their exercise in first thing in the morning. It's like their dose of medication in addition to their actual medications. So that's important to consider as well. And again, if you're in support groups, you're hearing that as well from other folks, and hopefully that can help motivate you to get your exercise in as you see that improvement in symptoms. And just work together with your doctor in terms of that treatment plan to get that on time as good as possible. And so let's talk about these different on and offs. So a partial on is where you feel like you're sort of between an off and an on. So you're not quite able to do everything you need to do, but you're not fully off. Your tremor's not as bad as it could be at times when you've had a dose failure. And what this means is you've had your medication and it doesn't actually help you feel on. And we feel that that potentially is related to GI issues. So maybe GI absorption issues, medications not getting to the brain where it needs to go. Early morning off, so poor control of motor symptoms when you wake up. The issue here may be that it's been some time since you've had your dose from the night before, and therefore it's going to take a little bit of time for your medications to get to therapeutic level during the day. Wearing off means that you lose that efficacy of the medication prior to each dose. Usually it's about 15 to 30 minutes, but if that time starts to increase and creep in, you definitely want to talk to your doc. If it's 15 minutes and you're aware that it's coming, but it's not a big problem, then usually you can continue with your current regimen and not lose any quality of life. But if you're looking at 30 minutes, 45 minutes, an hour, of each dose interval, that's a number of hours during the day that you're just waiting for your medications to kick in. And we don't want you to feel like you have to live by the clock in terms of planning your activities. Certainly planning your day is important, but if you're finding that every 3 hours you've got 30 minutes or 45 minutes where you're just not feeling well, that's a lot of time in the day that you could be using in other ways that make you happy. And unpredictable offs, this is where you've taken your medication exactly as you need to, and you have no idea why the medication's just not really kicking in. And so those are really the different types of on-offs that we can see. Sometimes patients will ask me, I don't really see the difference between on and off. And so this is quite common early on. So when the medication is working well, you may not be aware of that on-off. And it could be because you have enough of those dopamine nerve terminals that you're storing that dopamine and releasing it as needed. So you're not aware of the on-off. Another issue that could be happening if you're not experiencing on-off is that you could have a Parkinsonism. And in these cases, we don't see that specific, very brisk or robust response to levodopa to where you can definitively determine on-off. But if you're not sure about your medications and you talk to your doc about a trial of going off the medication, and then you see that over time, you're actually better on the medication than off, then it may be better to stay on the medication and that it is doing something for you, but it may not be that sort of brisk or robust response that patients with idiopathic Parkinson's can see. And so off time is really experienced very differently by every person living with Parkinson's. Motor symptoms that can pop up are what we've talked about before in terms of tremor, stiffness, slowness, trouble with speech, trouble with balance. Non-motor symptoms, though, can also accompany off time. Sometimes it can happen before the motor symptoms kick in. Sometimes that's the only symptom that you have. So it's very helpful if you're having anxiety, fatigue, pain, sweating, slowness of thinking, to determine, is it following a pattern? So is it happening, for example, just in the mornings? Or is it happening 30 minutes prior to each dose? So that can actually really help your doc in terms of determining how to manage those symptoms. And it is common that dopamine is not the only neurotransmitter issue that we see in Parkinson's. We can see serotonin levels affected, norepinephrine. And so when those neurotransmitter levels are affected, you can sometimes see these non-motor symptoms as well. So you may need a different approach other than dopamine. So it's important to talk to your doc about what you're experiencing in terms of non-motor and motor symptoms. And it can vary day to day as well. Greater than 90% experience at least one off episode per day. 65% can experience at least 2 hours of off time, and greater than 20% can experience more than 4 hours of off time per day. And so it's very important to, if you can, sort of determine how much of the day are you losing to off time, and discuss that with your doc so you can, develop an approach to handling these off periods. And so signs of off time can really vary greatly among folks with PD, as we were saying before, but we do know that more than half don't discuss their wearing off symptoms at every appointment. And it may be that you're concerned about adding another medication. Maybe you're tired of medications. Maybe you don't want to discuss that with your doc because you're afraid that that means they're going to give you another medication, another whole list of adverse effects to think about. But know that there are some options for medications to potentially consolidate some of your medications, to where if you're on two, there might be a medication that would allow you to take just one all-in-one type of medication that would address some of the wearing off symptoms. So it actually might be helpful to know that maybe your two medications could turn into one. So don't be afraid to discuss these. Again, quality of life is what we're looking at here. And your docs will talk to you about adverse effects related to the medications. And my, really my goal is to make sure that the benefit of any medication outweighs any adverse effects. And so please do talk to your doc if you're experiencing any of those adverse effects, so they can get you on the medication that works best for you. And don't just accept being fine if you are having wearing off. Again, please do talk to your doc, because there are ways to allow you better on time. So how Parkinson's medications work, the gold standard is levodopa, so that replaces depleted dopamine. It's paired with carbidopa, and this prevents nausea by preventing the breakdown of levodopa peripherally, and it allows that levodopa to get up to the brain so that it can essentially turn into dopamine at that synapse so that those nerve cells can communicate well together. And an LD dose or levodopa dose is intended to return your dopamine levels to normal, but the effects can wear off as your body uses it up. So I have patients that will tell me, if I have a really active day, boy, my medications don't seem like they work as well. Some people will say they need to keep exercising, and that helps them, with making sure that their medications stay on target, or their levels stay on target. So it really depends on you as an individual, but be aware of those symptoms and discuss that with your doc, because again, your doc may be able to adjust the timing of your medications on days that you are more or less active based on how you're feeling. And so good on time, this is sort of the Goldilocks, the just right. This is that therapeutic level that is not too high, it's not too low, and you're able to do everything you need to do, and your PD symptoms are managed well enough so that you can function. But what can happen over time is that as those dopamine nerve terminals drop out, you may be more dependent on the levels of the exogenous or the oral medications that you're taking, or the medications that you're taking. And so you can see more off time. You can see more dyskinesias. The off time can relate to potentially GI absorption issues, as I said before, or just the pharmacokinetics of the medication. So if you're taking a very short acting medication, that means there's more time that it needs for it to kick into your system, and it wears off more quickly. So you're going to have that off time. A more potent medication potentially is going to give you more dyskinesia. So the goal is really to get you into that good on-time zone. And what are the treatment options? So increasing your dose if you're having off periods, or the frequency of your carbidopa-levodopa medication can be helpful. As we said, nurses and doctors also are having difficulty potentially with increasing dose frequency. So we want to make it as easy on you as possible and try to reduce frequency where we can, just so that you're not, again, living your life by the clock in terms of when you need to take your medications. We could add an MAOB inhibitor, and this prevents the breakdown of dopamine. So it allows that dopamine to sort of stay in the synapse longer. That would include a medication like rasagiline or selegiline. Adding a COMT inhibitor. So this is a medication that prevents breakdown in another pathway called COMT. And examples here include Comtan or apicapone. Those are commonly used in conjunction with levodopa preparations as well. You could add a dopamine agonist. These are medications that aren't quite levodopa, but they fit into the receptor like levodopa would. And so it allows for some relief of the amount of dopamine that you might need to take levodopa. It also tends to last a little bit longer. However, these medications are associated with a number of side effects. Impulse control disorders, sleepiness, swelling of the feet, sometimes hallucinations. Sometimes, more often than levodopa, you'll see a drop in blood pressure with standing, so dizziness can be a common side effect. So we proceed with that medication with caution. And really, anytime we're adding a medication, we always want to discuss with you the potential side effects. But what I would say is if you're experiencing something new, even if you haven't heard it from your doc, tell them about it so that they know what's going on, and they can tell you, yes, that's an adverse effect, or maybe there's something else going on. Let's take a look at that more closely. And adding a rescue medication. So this is a medication that when you're very off, let's say you're frozen, can't move for an hour in the morning. This is the type of medication that you could take that can get you moving until your oral medications kick in. So examples here might be Inbrija, or Apokyn is another option of a rescue medication. Sometimes just immediate release carbidopa, levodopa, a half tablet can do the trick there. Adding amantadine or an adenosine A2A antagonist can be helpful. So amantadine is an older medication, uses a flu preventive that has been determined to help with dopamine release, and has a few other mechanisms in terms of how it can help with both off time, but also dyskinesias. And an adenosine A2A antagonist, right now that's istradefylline or Norians is that medication. Or you could switch to a longer acting carbidopa levodopa. So again, that's an option where you might, let's say you're on an IR, you're on a controlled release, you might be able to combine those two into one. And so that's what we have here. Those preparations, the immediate release, that works fairly quickly, 15 to 30 minutes, probably lasts an hour and a half, 2 hours. If you're further along on your timeline of Parkinson's, of dealing with Parkinson's. Controlled release may last a little bit longer than immediate release, and release a little more slowly into your body. This can be variable in terms of dose to dose, is what I've heard from patients. So one dose may last 3 hours, another dose may last 2 hours. It may stack, meaning that towards the end of the day, you have more dyskinesias because that has really accumulated throughout the day. And then we have extended release, which is bundled with multiple ingredients to release medication rapidly. So like immediate release plus the CR ideas are all in one capsule. And so the idea here is let's combine the best of the immediate, so get that in your system, and then 2 different preparations of a controlled release to allow you even more time potentially between doses and better control of on time. And so each version, contains levodopa. It's just different formulations based on what you might need and based on where you are in terms of your on and off symptoms. And as much as we can do, again, to increase that timeline of efficacy from dose to dose is better for you in terms of less dosing throughout the day. So selecting and managing your treatment, the right medication, of course, can make your life easier. Always talk to your doctor about that. Bring your care partner to take notes and remind you of questions. That's always helpful. We do enjoy having care partners in as well. And sometimes I'll have spouses say, well, I'm going to tell on him, and they'll tell me things that you may not want to tell me. But all in all, our goal as a team is to work together to provide you with the best options, the best opportunity that we can in terms of managing your symptoms as best as we can. And so don't be afraid to have your care partner tell on you a little bit. We're here to help you. And good time, of course, can increase your quality of life and hopefully keep you independent for longer. So your doc generally will start you on a lower dose and then increase it as you become used to the medication and as you become aware of the benefits, and then titrate further based on what symptoms remain. So keeping track of those symptoms over time can be helpful. Don't be afraid to advocate. So when something's not working, like I said, don't wait the 3 months, talk to your doc or get some information from the office in terms of who exactly can you talk to about any issues you're having. And so you can get that good on time sort of within reach. And then there's this concept of dopamine. So dopamine and dopamine. So this is a concept that's been developed by researchers and doctors, one of whom was living with Parkinson's. And the idea is that if you have control over your treatment plan, this can really equate to a lot of hope in terms of managing your symptoms, managing your quality of life. Be curious, ask questions, talk with other people living with PD, go to the support groups, get some ideas, talk to your doc, and, remain active as well. Don't forget to take your dopamine, and know that, you're not alone. Your caregiver, your healthcare team, your family, researchers, the worldwide PD community are all in this with you. And with this legislation that's on board, we're hoping that we have even more resources that we can provide. So keep in mind that off time can be different for everybody. It can certainly, impact your life dramatically. It's important to talk about it with your care partner, with your doctor, and see what else we can do in terms of increasing your quality of life. As time goes by, it is very common and almost universal that your medications will need to be adjusted. So be aware of those symptoms. And if you're not sure if it's a PD symptom or not, mention it to your doc. If they don't feel that it is and refer you to another doc, then they can address any of the non-motor symptoms that may not be addressed by dopamine. And the goal really with managing Parkinson's is to improve your on time, increase that good on time, without those motor complications. And so with that, I am happy to turn things over for any questions and comments, but thanks so much for your attention for today's program. And again, thanks to PMDA and Amneal for putting this on for us.
Thank you so much, Dr. Mahant. That was wonderful. So I do have a few questions that came in. The first one, when you were talking earlier about the toxin exposures, this person was wanting to know, is there any way to test for that to determine what environmental toxins they might have been exposed to?
Not yet. Yeah, that's a very good question. I know that there are some naturopaths that talk about some screening, hair follicle, hair sample screening, even blood work for heavy metal screening. And, there may be some help with that. We don't have a lot of data on that information. I don't think it's harmful to take a look at some of those things. You just want to be careful with kind of promises of, okay, we're going to, do this chelation therapy and get rid of, you've got a cavity and some fillings and maybe you've got mercury. And if you don't have a lot of hard science behind that, I would hate for you to go through a treatment that hasn't been very well proven. So there's not a whole lot of that that I would recommend. As far as testing, what we do recommend is certainly vitamin testing. So anything that can affect nervous system health, B12, vitamin D, folate, thiamine, just your regular blood work that you get on an annual basis is important, thyroid. Those things are important to test as far as labs. I don't know at this point that we have a whole panel of tests that we would say definitively, okay, these are toxins we want to screen for. We're just not at that level yet, unfortunately. There have been a few studies that have looked at air quality. And what's interesting is that there is a preponderance of Parkinson's that we see in certain areas of the country where there is a poor air quality. So that's one thing that we've determined as well, that researchers have determined, separate from, pesticide exposures, TCE, things like that. So that's another thing to keep in mind. So all the more reason to advocate for, as clean air as you can possibly get. Clean water, clean air, those are very important in terms of our general health. So it's important to, make sure that you're still interested in those things that affect us day to day in terms of our health.
Thank you. I missed it, but I'm sure that everybody enjoyed that. So the other question was related to some of the causes. And you had mentioned Muhammad Ali, and we know that he had repeated head injuries from boxing. But this person wanted to know how severe or how many of those actually put you at risk.
We don't know for sure, but one thing that I would say is multiple concussions throughout your life does increase your risk of neurodegenerative conditions in general. So Parkinson's, dementia, even ALS. Many of you have probably heard of, the NFL, increased preponderance of those neurodegenerative conditions in that population, and they certainly are a population that, has been unfortunately through their, it's an occupational hazard that they've had a number of concussions throughout their life. And so we don't have a specific number, but that I would say, as much as you can do to keep your concussions to a minimum, that's ideal. So, of course, the NFL and, similar sports, hockey and such, that, like I said, is an occupational hazard, but staying away from head injuries as much as you can is definitely recommended.
Okay. And you also, in this presentation, talked a little bit about tremors, and I think you referenced essential tremor. So someone wanted to know, can you have both essential tremor and a Parkinson's tremor? How do you differentiate between the two types?
Great question. So essential tremor versus Parkinson's, usually it is the company it keeps. So with essential tremor, the reason it's called essential tremor is because the condition is essentially just a tremor. And so that tremor can be quite severe. So I don't mean to minimize the tremor by saying just, but it's not associated with slowness or stiffness or balance problems as much as you see with Parkinson's. So there can be some associated symptoms, some balance changes that can occur over decades. So if you've had essential tremor for 20, 30 years, wide-based gait and difficulty with your balance can be present, but you don't see the freezing. You don't see necessarily the same sort of stooped posture and other shuffling gait that you would see with Parkinson's. So it's really the company it keeps. There are some tests now potentially that can be helpful in terms of differentiating just through one of the, there is a technique, the skin biopsy can determine if you have a protein, alpha-synuclein, and if that's present, that's most likely a Parkinson's condition. Sometimes, though, you can have both. So a patient may have essential tremor and they may be at increased risk of developing Parkinson's. So there was an abstract that a movement disorder specialist, Dr. Evidenti, did where he looked at skin biopsy in patients with essential tremor who had developed Parkinson's symptoms over time, and they tested positive on the skin biopsy. So there's a slightly higher risk over time in essential tremor patients of developing Parkinson's. So if and as symptoms start to change, it's important to consider with your doc what the options are. Is it worth testing? Is it worth, switching up your treatment regimen or adding medications if you have more of an action tremor? If you're thinking about DBS, considering the targets of DBS, which is deep brain stimulation, that can actually help with tremor. So it might be worth, having that conversation with your doc in terms of what's the best approach here. If it's, a lot of tremor and minimal Parkinson's symptoms, sometimes the VIM thalamic approach may be better than GPI or STN. So important to discuss with your doc in terms of the, both the diagnostic and the treatment implications, medications and surgical if that's opted for.
Okay. So you talked about off and the different types of off. So this question was, I have dizziness, sometimes fuzziness in my head. Could this be off?
Very good question. That's a excellent question and frequently asked. So one of the things that can help determine would be when that happens. So does the dizziness happen, 30 minutes or an hour after each dose of your medication? Or is it happening 30 minutes or an hour before your medication? And again, what's the company that it keeps? Are you having more tremor at that time? Are you having more stiffness and slowness? So if it's occurring before every dose and it's associated with other motor symptoms, then it could be a wearing off. If you're having it at peak dose, so 30 minutes or an hour after each dose, that could be a side effect of the medication. Or perhaps you're dehydrated and the medication is amplifying that symptom of dehydration, which is dizziness, by sometimes lowering your blood pressure at peak dose. So the timing can really be helpful. If it's just a generalized symptom, it could just be one of those symptoms that maybe is not time locked. Or is it a side effect of one of your medications if it's there all the time? So those are important things to consider in terms of timing.
And this is an interesting question. This person wants to know, does knowing the cause of my Parkinson's impact how I treat it?
So very good question. I don't know that we have the answers to that. Muhammad Ali, for example, although he was, he had that risk of the head injuries as the most likely, his most likely risk factor contributing. He was, my understanding from the docs that treated him with permission, they were saying that he did have signs and symptoms of idiopathic or typical Parkinson's as well. He may not have responded well to some of the medications, which is why maybe you were seeing him more off than a lot of folks that you might see, especially towards the end of his life. So we still try the same medications regardless of the cause. There are some cases of vascular Parkinson's where it might be due to stroke, where a patient may respond to levodopa still, even though it's not idiopathic Parkinson's. So we have generally a very low threshold for using levodopa to manage or to at least test and trial in patients, as long as they're tolerating it, to see if it's going to be helpful. So generally, I would say in most cases, we don't know the cause. And so we are going to try medications that we think will help, whether it's toxic, vascular, or otherwise. But it does, if you know the cause, sometimes it might give you a little bit of guidance in terms of how far should we go with this dose? Should we really be pushing this dose? For example, in a patient who's had a stroke or multiple strokes and they have Parkinson's and they're not responding to low doses or they're having side effects, is it worth putting them through multiple trials, higher doses or other preparations? It may not be worth that. So knowing that in advance can help guide sort of how far you go with treatment.
So speaking of treatment, we've had some questions about balancing the levodopa. What is the maximum dose? Can you talk about how the progression of the disease may require the increasing of the dose or adding additional medications, sort of like just trying to find that balance. And I know you talked about the different formulations. So one question came in, I wasn't exactly sure what they were asking, but I think it was around trying to not have to necessarily increase the amount of levodopa, but still be able to have the benefit.
Right. So really in terms of maximum dose, which is the first part of the question, there's really, we go by symptoms and side effects. So if the medication is covering your symptoms, and we always start low, go slow is our motto. And so you tell us how your symptoms are doing. And if you're tolerating it and you're still having symptoms, we will likely either recommend an increased dose, or we might recommend a helper medication, depending on what you're reporting. So if you're finding that there are predictable offs, we might change the formulation. There is, we would like to potentially, again, reduce the number of doses per day if we can, and stretch out that dose interval in those cases. If you're having a lot of unpredictable time and a lot of dose failures, then we might consider add-ons that have less of an issue in terms of the wearing off. So one might be Duopa, for example. Hopefully the patch-based pumps will be coming forth as well, and that can help with those unpredictable offs potentially. There may be some add-ons that we can add in some cases that could help with some symptoms that are a little less predictable. Dopamine agonists potentially MAOB inhibitors. So there may be some add-on medications, I would say, in the case of unpredictable offs, where you can't really predict when it's going to happen, that might be a little bit better. So it really, I think, again, the timing, determining when those symptoms are happening, that you're noticing in terms of breakthrough symptoms, that can be helpful in terms of guiding treatment, and the severity as well. So, look at the severity of your symptoms, talk about the severity of your symptoms, and your doc can decide, is it worth a more invasive treatment at this point, or are there some strategies? Are there some side effects that we really want to avoid? So we want to avoid certain medications like amantadine or dopamine agonists, for example. In cases where patients already have a lot of swelling in their feet, we may not want to expose them to that. Or in a patient who has maybe some mild memory issues, we don't want to push them into a situation where the medication is worsening those symptoms or potentially causing hallucinations. So it's really very individual. It's a great question. It's so individual, though. It's hard to sort of give you a one-size-fits-all answer. But what I would say is, knowing when your symptoms are happening, how severe they are, is very important to discuss with your doc in terms of determining the right approach.
So, the entire country has been dealing with extremely hot temperatures. And so we've had some questions lately and today about how do high temperatures like we've been experiencing, especially in places like Arizona and Florida, affect people with Parkinson's.
So yeah, the being prone to drops in blood pressure that can be fueled by both the Parkinson's and your medications is probably the biggest concern. So staying hydrated is very, very important. The other thing is temperature dysregulation. So your ability to regulate your internal temperature can be affected by Parkinson's in general. So it affects those autonomic nerves, which are important in sort of the cooling and the heating mechanism of your body. So it manages your sweat glands, it manages your hair follicles, which are all mechanisms by which we can regulate temperature. Also, it controls constriction and dilation of your blood vessels. So those autonomic nerves can be affected in typical Parkinson's. It can also be affected in Parkinsonisms like multiple system atrophy. Those can really be affected to a more significant degree in that population compared to the typical PD patients. So those would be probably the main things. I would say hydration is key. Sometimes electrolytes, that IV. I wish I had stock in that IV hydration, liquid IV hydration, because I recommend it to all my patients. I promise I don't have stock in it. But you can get it at Costco, and the packet is probably the best deal. Costco and Walmart, I think. But anyway, it's a little packet you can just throw in your water, and you can have that. It's less sugar generally than Gatorade and things like that, which are other approaches as well. But being in tune with, what you need throughout the day when temperatures are too hot, avoiding, peak sun time, those are important. Also, separate from that, there is a risk of melanoma with Parkinson's. So you want to make sure that you're staying out of the sun, not just for the heat potential, but also for the sun exposure. And so make sure that, you know, you're using adequate sunscreen and that you're getting your yearly derm checks as well to make sure you're not developing any melanomas, especially if you potentially have risk there in terms of other skin issues, or if you're if you have very light skin as well, fair skinned, then you might be at more risk.
So I'm going to pair a couple of questions since we are getting close to time. One of those was, can you recommend a proactive diet regimen where it would be a good place to find information? And then also, can you speak to the benefit of adding vitamins such as vitamin B?
Right. So as far as the diet information, there's some great resources out there for you. I'm sure PMDA has a number of programs on that specifically. So you're welcome to look through the library of programs that PMDA has. There are really, but it boils down to the Mediterranean diet, or the MIND diet, really. And so what that is basically a lot less processed foods, less sugars, more whole grains, more lean meats, you know, fish as opposed to red meats, for example, less heavy on the carbs in general, more fruits and vegetables, less saturated fats. So not so much butter, but more olive oils. So those are kind of the basic strategies, I would say. But if you want to kind of learn in depth, though there are a number of programs out there that sort of review, you know, food options and the specific dietary recommendations. As far as supplements, my approach is really to make sure that you either with your neurologist or your primary care doctor are monitoring your levels in terms of vitamins. I don't just recommend vitamins. A lot of the studies that have been out there have been smaller. I think there have been a few that are looking at sort of high dose thiamine and things like that. I don't know that there's enough literature out there on that. Vitamin C, vitamin E have been looked at as potential antioxidants. Those have not been proven to be helpful in Parkinson's. So generally, my recommendation is to take a look at your levels, the ones that are, again, most important, B12, folate. You can check thiamine as well, vitamin D. Those are probably the most important things to be checking. If there's, you know, specific issues that you might be having, you know, your doc might recommend other things to check, but those are the main ones. And I usually recommend that you have those levels checked before you add supplements. I think it's a good idea to make sure that you're following those levels, and let that be your guide. And a healthy, you know, balanced diet is most important.
Awesome. Well, thank you so much. I know we are out of time, but this has
My
been
pleasure.
wonderful. We did get through quite a few questions, so thank you for that and those extra insights. So I know you've probably been on these before and received this, but we have a tradition at PMD Alliance that I'm going to invite everyone to engage in, and is that to thank you for your time by waving to you across the United States, and I
I
think
love
even
it.
outside the US. The wave of gratitude to you, Dr. Mahant, for spending your time with us and just helping us gain better insight.
Thank you so much, Eileen. I love seeing all your waves and all your smiling faces. It's great to see all of you. Thank you so much.
Thank you. And of course, we want to thank Amneal for this wonderful presentation. This foundational program is just so comprehensive. So we appreciate that. And of course, thanks for joining us, everyone. We'll see you real soon.
Bye, everybody.
Bye.